So today we're going to talk about how we use the MRI to differentiate the MS-like illnesses, NMO and MOG, from the more classic cause of optic neuritis, which is multiple sclerosis. So they're all going to present in the same way clinically, optic neuritis. So all of these patients have optic neuritis. Now, of course, there are differentiating features on the optic neuritis in terms of unilateral versus bilateral. But really, we're going to just be concentrating on the radiographic features that differentiate the three competing entities, NMO, MOG, and MS. So we'll just start with MS because that's the easiest one. In multiple sclerosis, the lesions are usually going to be periventricular, ovoid, and adjacent to the ventricle. And the more you have, the more likely it is to be that. So it's going to be white matter disease. And that white matter lesions are usually multifocal. And it'd be better if you had both an infratentorial and a supratentorial lesions. And because what we're trying to establish is radiographic dissemination in time and space, we'd like to see different age lesions. So on T1, it might be just a hole, a black hole. On T2, it's going to be hyper intense. And on gadolinium, it'll be enhancing if it's an active lesion. So the combination of multifocal, periventricular, ovoid, white matter lesions, infratentorially and supratentorially, with T2 hyperintensity, T1 hypointensity, and one or more lesions enhancing. This is what's going to characterize the classic presentation of multiple sclerosis and establish dissemination radiographically in time and space, different locations and different times, because that's an old lesion, and that's a less old lesion, and that's an active enhancing lesion. And one of the places it likes to go is the corpus callosum, and it makes these Dawson's fingers. So that'd be kind of like a typical MS profile. The enhancement in optic neuritis also normally is just intraorbital and a short segment. So a short segment of the nerve itself enhancing, that would be a typical feature of multiple sclerosis related optic neuritis. In contrast, NMO likes to go to very specific regions of your brain, and it's antibody against the aquaporin 4 channel. And so the aquaporin 4 rich areas are where the NMO is going to be causing a lesion. So as opposed to the periventricular white matter lesions of MS, the NMO regions are going to be concentrated around the NMO rich regions, and so that's going to be the hypothalamus, the chiasm, and that's what's going to be producing the hypothalamic presentations, which are going to be like symptomatic narcolepsy, the chiasmitis, and that's going to produce the bilateral vision loss with optic nerve enhancement. And so instead of just a focal lesion like this, you'd have longitudinally extensive or chiasmal enhancement in the NMO pattern of optic neuritis on the MRI. And then if you just drew a little line around here, you go all the way down to the area postrema, which is where the vomit center is, and that's going to produce the nausea and vomiting. And in the brainstem, that's going to produce the intractable hiccups. And then the periependymal areas are where the enhancement's going to be. So we're going to see different types of lesions in NMO. They're going to be hitting the aquaporin 4 rich areas, and if you just drew a line around those aquaporin 4 rich areas, you'd see that it's not really like the Dawson's fingers of the periventricular white matter of multiple sclerosis. So it's a different pattern of disease. Aquaporin 4 rich areas versus periventricular white matter. That's the main differentiating feature between MS and NMO. MOG can look exactly like NMO. However, MOG and the pattern of MOG enhancement in the optic nerve is usually the sheath. So it's like in the sheath. So it can look like that tram track sign that we talked about in the videos for meningioma. And in coronal view, it'll be like a target lesion. So it'll be the enhancement will be in the sheath. And often that enhancement is very shaggy in the sheath. So when you're confronted with an optic neuropathy patient in a young patient, we should be thinking about optic neuritis, acute unilateral loss of vision, retrobulbar, optic neuritis. We're going to be looking for that kind of enhancement, short segment intraorbital, and we're going to be looking for periventricular white matter lesions, ovoid, infratentorial, supratentorial, different ages, T1 hypointense, T2 hyperintense, and gadolinium enhancing. This would be a classic MRI finding for MS-related optic neuritis. If, however, the optic neuritis is atypical, older patient, non-white patient, Afro-American, Afro-Caribbean, Asian patient, bilateral, swollen disc, longitudinally enhanced, extensive enhancement, or any kinds of white matter, non-white matter lesions in the aquaporin 4 rich areas, or presentations with intractable hiccups, nausea, vomiting, or symptomatic narcolepsy. Those are the presentations of NMO. And then MOG, similar to NMO in a lot of ways. It can mimic it completely, but also the distinctive radiographic feature, sheath enhancement. The tram track sign, target sign on the post-contrast orbit, different than the parenchymal enhancement of optic neuritis. And that's how we use the MRI to kind of differentiate the three competing entities, even though they all presented with optic neuritis.